We're getting ready to start our presentation today of the 2017 Winter Communicable Disease Forum webinar. Thank you for joining us. We have great presenters on tap for you today, but I just have a few things that I wanted to announce before we get started. My name is Laura Taylor, and I'm staff here at the Communicable Disease Service. And I'd like for these slides to move. There we go. So today's webinar is being recorded and archived. It will be posted to the New Jersey Department of Health website. And you can see here is a screenshot of where you can find it. It will be where the prior winter forums were posted under the CDS page for Communicable Disease Service under Education and Training. Continuing educations are offered for this webinar. We offer 2.0 public health and nursing contact hours. Credits are provided to those who attend the webinar live. So anyone who watches the webinar once it's been archived and posted is not able to earn credits, but they can still listen to the fantastic presentations given by our staff here. But again, please remember, in order to earn credits, you must watch the webinar live and also be registered on GoToWebinar and NJLMN. Please note that as of 8:30 this morning, NJLMN has been down. I don't know what happened. I don't know if everyone here crashed the system, but you can't access the slides. However, you can access the slides on your screen under handouts. So you can view along with us by looking at the handout section, and then I will email everyone when NJLMN is back. We already have an email out to the folks who work the system to see when they anticipate it coming back up. So if for any reason you're not registered on NJLMN and are interested in earning credits, please just send me an email and I will make sure that you get the evaluation. My email is laura.taylor@doh.nj.gov. All right. So if you have questions during the webinar, and we hope that you do, we'd like you to let us know. So you can see here in this blue box, which you also have on your screen, just click on the little arrow that says questions and write us your question, and we will hopefully get to address your question at the end of the webinar. We're going to hold all questions until all presenters have presented, and then we're going to address the questions. Please note that you are in listen-only mode, which means your phone line is muted. So the question really is how you can communicate with us. Also, you can also see there's a chat box underneath the questions. Underneath, you can also send us a little message if you'd like to chat with us. So if there's handouts, and there are, there would be in the handout section. So again, you can follow along with us. The handouts are the same ones that were posted to NJLMN. But seeing as how NJLMN is down, it looks like handouts is your best option right now. Sorry about that. We are working with NJLMN, and we'll let you know when the system is back up. So after the webinar, everyone I'm sure is interested in earning some credits. So you will receive a link later today, probably this afternoon, especially if NJLMN does not come up until much later. We will be using NJLMN to email everyone the link to the evaluation. So you'll get that, at some point. So click on the evaluation. There are about 21 questions this time because we have a couple extra questions that we want to ask you. So click on the evaluation, answer the questions, and please note we'd like you to complete these within 5 days. 5 business days. And once the evaluation closes, that's when your certificates, with the typo, will be emailed to your NJLMN address, and or your attendance will be verified in NJLMN whenever it comes back up. So anyone who does not complete the evaluation will not receive credits. Okay, so please be on the lookout for that link, but we will have to wait until NJLMN comes back up to send that link out. I just want to let you know that some of the extra questions on the evaluation are related to the CDRSS, the Communicable Disease Reporting and Surveillance System redesign. So our CDRSS team is looking for input from you, CDRSS users, about training for the new system and how would you like to be trained in person, webinars, and so that is pretty much what the extra questions are going to ask you. So please take a moment and complete those questions on the evaluation as well. So that is what I just talked about. There we go. So please answer our questions about CDRSS redesign and training. And don't forget, register on both GoToWebinar and NJLMN. And we will again be in touch as soon as NJLMN is up and look for that evaluation. So, before we get into our speakers, I would just like to take a few minutes and welcome Dr. Sharif Ibrahim. He's our new Regional Epidemiology Program Manager. Sharif, would you like to say a few words?
Good morning, everyone. My name is Sharif Ibrahim. Thanks, Laura, for introducing me. I've been with the Regional EPI program for the last 3 months. I would like to welcome you today for making a webinar. I am really excited to be in New Jersey, and I look forward to working and meeting all of you hopefully soon. So I want you to enjoy and learn from today's webinar. We have really great speakers. So before we start with our first, just make few announcements. My first one is the New Jersey Department of Health is creating a roadshow to assist you in hepatitis case classification with the new case definition. It's going to be an hour-long interactive training, and our regional AP will present this to their regions. My second announcement is the regional reports, the quarterly report, have been sent out. And if you did not get yours, please contact your regional AP. Last announcement is please mark your calendar for our next webinar in February 13. We will have 2 public health credit and nursing hours. So please register now to the GoToWebinar and NJLMN. We will be sending the link very soon. Now I will move to our first speaker. This is Patricia Barrett, and our topic is new antimicrobial resistance activities, surveillance, and response. There you go.
Thanks, Sharif. Hi, everybody. Like Sharif said, I'm Patty Barrett. I am the antimicrobial resistance coordinator for this state, which means that I work on activities related to various different drug-resistant organisms. And today I'm really going to be talking about surveillance and response for particularly a set of organisms that we commonly call CRE. So today I'll be, of course, going over what CRE is and giving a little bit of background about the organism. And I'm going to speak a little bit more broadly about a new national surveillance program and the CRE surveillance that will soon take place in New Jersey. Finally, I'm going to talk about how we respond to reports of novel resistance organisms, just like CRE when identified. So to start us off, let's talk about Carbapenem-resistant Enterobacteriaceae, what I often will be referring to as CRE because it is quite a mouthful. So why do we really care about CRE? On a pretty high level, CDC has categorized CRE as an urgent resistant threat. CDC estimates that there are over 9,000 CRE infections each year, and that over 600 patients die as a result of these infections. Now, obviously, CRE is quite serious, but it wasn't really until recently that CRE and other resistant organisms were really defined and first tracked by folks in public health. So how do we define CRE? Now, Carbapenem-resistant Enterobacteriaceae is actually more of an umbrella term. because Enterobacteriaceae is actually an entire family of bacteria that commonly cause infections and often colonize the gut and GI tract. Now, this family includes many different species of bacteria. Some of the more common of which that you probably hear about include Enterobacter, E. coli, Klebsiella species, Salmonella, and many others. And so when we refer to CRE, we could be referring to a Klebsiella pneumoniae infection or an E. coli infection, only if, of course, the organism is resistant to carbapenems. Now, carbapenems are a class of antibiotics that are commonly used to treat infections that are resistant to other antibiotic classes. For example, patients that have E. coli infection in their urine can't usually be treated with first-line options. So carbapenems in these cases are our best antibiotic of choice. Carbapenem drugs also have what we call broad-spectrum antibacterial activity, which means that carbapenem antibiotics, this class of antibiotics, can be used to treat different kinds of infections, including both gram-positive and gram-negative bacteria. So resistant to these broad-spectrum drugs means that we really lose some of our most versatile treatment options. And unfortunately, folks with carbapenem resistant have very difficult to treat infections and may eventually develop pan-resistant infections with no routine treatment options. Now, of course, just listing a big family of bacteria and a class of antibiotics isn't, easily defining CRE. So the Council for State and Territorial Epidemiologists, or CSTE, and the CDC actually went on to develop a more standard way for us to define CRE. Now, keep in mind that this definition refers to an isolate and is not a case definition for a patient. So the surveillance definition really defines CRE with two different ways. The first one is by, of course, completing antibiotic susceptibility testing and finding that an isolate that is an Enterobacteriaceae resistant to at least one of the listed carbapenems. And additionally, testing for what we call a carbapenemase is another option for identifying CRE. Now, not all CRE have what we call a carbapenemase. So when we think about CRE, we should think about them like this. Essentially, of all Enterobacteriaceae, or this light, bigger blue circle, there are some that are carbapenem resistant, and we call these CRE. And of those CRE, some of these organisms produce what's called a carbapenemase. And this group is called CPCRE, for carbapenemase producing CRE. It's pretty literal. So carbapenemases are these enzymes that break down carbapenems or other antimicrobial agents, making these drugs ineffective and essentially causing resistance to these drugs. Different genes allow bacteria to produce carbapenemase enzymes, and unfortunately many of these genes are plasmid mediated, which means that these genes can be easily shared across different species of bacteria. Now, there are many different types of carbapenemase genes, some of the more notable of which are listed on this slide here. One organism can actually have one or even more of these carbapenemase genes at once, but the most common one that we see in New Jersey is called KPC, which stands for Klebsiella pneumoniae carbapenemase. Now, to make it even more confusing, KPC genes are not just found on Klebsiella pneumoniae species, but can be transferred to other Enterobacteriaceae, such as E. coli. So it's a great example of how plasmid-mediated genes can share resistance across different organisms. Now, unfortunately, most clinical laboratories don't test for these enzymes regularly, so it's still rare for facilities to be able to differentiate CPCRE from just everyday CRE, and even more rare for them to identify the actual resistance gene that's causing carbapenemase production. Now, the ones that are listed on this slide are the genes that are probably the most relevant to us in New Jersey, as these are the ones that CDC looks for and will soon be tested by our state public health lab in New Jersey. So I want to talk a little bit about surveillance. Now, because of the concern of CPCRE spread and the possibility of other novel resistance mechanisms to come about, CDC and here in New Jersey, we're beginning laboratory surveillance for some of these various organisms. Now, on a national level, this surveillance really started when CDC created the Antibiotic Resistance Lab Network, or the ARLN. The ARLN was first started in 2016 when CDC funded all state health departments to build testing capacity and identify CRE in different carbapenemase genes. The overall goal of the network is to enhance the detection, response, and prevention of resistant threats in the United States. And to do this, there are many different projects that are happening with the ARLN. 3 of the major ones that are forming in our region are listed up here. But the one that I'm going to focus on today is going to be the first one, CRE surveillance. Now, the other 2 are important, but they're just in the beginning stages, so they're not going to affect us anytime in the near future. Now, really briefly, I just kind of want to familiarize you all with the setup of the ARLN. As the name really suggests, the ARLN uses what we call a network approach. So there are obvious clear relationships and testing flows within this network to support activities across various levels, from the clinical laboratory to the national level. So to start off, individual clinical labs in New Jersey will be submitting CRE isolates for resistance testing each month, and those isolates will be sent to our state public health lab, otherwise known as PHEL. Now, I'll talk a little bit more about the testing that happens at PHEL in a few minutes, but once testing is completed at PHEL, any isolates that have odd or concerning results that may indicate novel resistance would be sent on to our regional laboratory for additional testing. In our case, New York State's Wadsworth Laboratory is our regional lab. So this is the lab where our isolates would be sent if we need further testing to be completed. The regional laboratories also support CRE colonization screening if that's needed during an investigation, and I'll talk a little bit more on this in a few minutes. Now, finally, CDC does service the entire network, and they're the ones coordinating and tracking the resistance results from this testing, and they're also the ones that are paying for the shipping and supplies for specimen collection and coordination between clinical labs all the way up to CDC. So thankfully, CDC allows us to have quick turnaround times and get isolates to and from different laboratories with pretty rapid speed. Now, as I mentioned, our regional laboratory is going to be the New York State Wadsworth Laboratory, and we're going to be located in the Northeast region for the ARLN activities, just like many other surveillance activities. Now, zooming in, I do want to speak a little bit more about CRE testing in New Jersey. Even though ARLN was first funded in 2016, it's taken our team and PHEL many, many months to get a lot of planning completed and validation for this testing. Before ARLN, PHEL was not doing any antimicrobial resistance or resistance mechanism testing, so this is a totally new set of activities, and there's a lot of work to get these activities built from the ground up. Now, we're nearly finished with validation, and so we'll start asking labs to regularly submit CRE isolates to our team at the beginning of the new year. I think our tentative start date is January 15th for isolate submission. Now, to start off, we're going to have 4 clinical laboratories in New Jersey that service healthcare facilities across all 5 regions to submit isolates when we're ready to start testing. PHEL will complete multiple types of testing for each isolate that's submitted, and that's going to include antibiotic susceptibility testing for different classes of antibiotics to identify possible pan-resistant isolates. It will also check for carbapenemase production by using what's called the MSIM test to identify whether an isolate would be a CpCRE. And they'll also test for some of the common carbapenemase genes that we talked about before. Now, I apologize. The combination of these 3 testing activities can really help us identify a few different kinds of resistance threat. The first one is going to be, of course, isolates that are pan-resistant or don't have any traditional treatment options available for treatment. We can also identify isolates that have one or more of these concerning carbapenemase genes, and we can also identify carbapenemase producing isolates that don't actually have a known carbapenemase gene available. So this would be a type of novel resistance that we'd want to identify and respond to as soon as possible. Now, I know that there's been a lot of lab speak and that it can be pretty intimidating with a lot of acronyms so far. But thankfully, the ARLN is full of a lot of great folks who are able to help us identify these concerning threats and coordinate a lot of these testing activities. And then our role really in public health is to really lead that response and investigation into these cases. So really, when we have one of these isolates reported and investigation is needed, what do we do? So depending on the type of resistant threat, there are a few different things that we'd be expected to do. But no matter what the threat is, our primary goal is to really prevent future transmission of whatever the organism may be. While it's really neat to figure out where somebody got a resistant bug, the frustrating part about most MDROs is that there's not usually a magically clear link between cases, and so transmission can happen at any time, even if there's the smallest lapse in infection control. So I'm going to talk a little bit more in depth on these 7 activities. So first off, when a patient with novel or concerning resistant organism is identified, the report usually comes from our public health laboratory and will come to the state or local health department. Obviously, we know where this patient was at some point in time because they had to have a culture collected for them to be part of this testing. Now, when the case is reported, our first step is, of course, to locate the patient. And in most cases, patients with these CRE infections require strong antibiotic therapies. So most often, they'll be in inpatient healthcare settings still. Some at-risk patients may be frequent flyers and have stays in both long-term acute care or post-acute care facilities as well as hospitalizations. So tracking a patient's travel between healthcare facilities may be needed at some point in time. But once we identify a patient's current location, the healthcare facility that they're staying at should be provided with infection control recommendations to prevent any additional transmission. In most cases, this includes placement on contact precautions and placing the patient in a single room. Whenever possible, we'd want to reduce the opportunity for transmission by also limiting shared equipment that's going into the patient's room or the healthcare providers interacting with the patient. Of course, facilities should also be encouraged to review their infection control recommendations with their staff and to audit compliance whenever possible to ensure that no transmission can occur. Now, depending on the type of resistant gene identified, CDC may request specific information on the patient and their healthcare exposures. Most pieces of information can't be taken from a patient's medical record, so a patient interview isn't usually necessary in these investigations unless there's specific questions or additional follow-up that's needed. Now, when we're collecting the case information, we also want to work with the healthcare facilities to identify potential close contacts of the case. In most instances, the need to identify contacts really depends on whether or not the patient was placed on contact precautions during their healthcare stay. If they were on contact precautions, then we would only recommend identifying contacts such as roommates and potential for screening. If not, if the patient was not on contact precautions for their entire stay, we would want to identify patients that shared a unit with them for 3 or more days, but were also not on contact precautions. Now, I realize it's a bit of a tricky calculation, but CDC has really determined that these are the primary ring of at-risk folks for transmission, and so they're the most sensible group to include for contact screening or for screening for CRE colonization. So unfortunately, CRE screening is not very glamorous. As you can see from the pictures, it does require a rectal swab to be collected from each patient. Our regional laboratory requires that a very specific swab is used for CRE colonization screening. So they will actually ship the swabs and specimen collection supplies directly to the facility that will be doing the screening, and the facility staff member would be asked to swab the patients that need testing. After specimen collection, the swabs will be shipped directly back to the regional laboratory, where the regional laboratory will do a rapid PCR test to identify CRE colonization. This is actually a very quick turnaround time, so we can get results in usually 1 to 2 days. And if the patient is colonized, then we would, of course, want to collect basic information about the patient, and based on what we learn, we would consider additional testing at the laboratory and consultation with CDC. Now, in the case of a contact being discharged from a facility, or if the patient's provider refuses to swab the patient, there's not really much that we can do in these cases. Sometimes patients will also turn down testing when we ask for their consent. And most of these times, we would just consider those contacts lost to follow-up and we would need to move forward with testing those who are available and consenting for screening. Now, while all of this screening is going on to identify colonized folks, we also want to ensure that the clinical laboratory is also on the lookout for possible infections of the same organism. So to do this, we would recommend that the affected facility monitor for other clinical isolates that are similar to the resistant bug that we're investigating currently. Now, folks with the ARLN usually help us determine what that sort of isolate would be on, that the lab should be on the lookout for. But generally, they would monitor for additional CRE isolates in patients with an overlap with the case that we first identified, say patients who shared the same unit. Then if another CRE isolate is identified, we would send these through with the ARLN for additional testing and follow-up to potentially see if there might have been transmission between these two patients. Now, the final step is going to be case rescreening. Now, this only occurs for some of the more rare resistant bugs, and this follow-up testing of patients is to really monitor for prolonged colonization, so we can help learn more about the organism and make sure that the length of infection control precautions are on appropriate timelines. Once patients get 2 negative consecutive screens or they're discharged from the healthcare facility, we would stop following up at this point. And yes, I do realize that these are 7 very big activities, and it would take a ton of time if we did this for every single report of CPCRE. But thankfully, CDC does realize that not all resistant bugs are created equal, and so we're actually breaking these organisms up into 3 different tiers. So we can kind of prioritize our efforts in investigation. So starting from the bottom, the more common Carbapenemase in New Jersey, that KPC, is what we consider the lowest tier, or tier 3. KPC is a pretty common form of resistance, but it's not endemic in the region. So we still want to focus on preventing transmission, but may not get into other activities like collecting case information. Some of the other Carbapenemase genes like OXA48, NDM, VIM, and IMP are what's called tier 2 because they're still pretty rarely identified in New Jersey. Since I've been the AR coordinator for about 2 years, we've only had about 5 or so cases of these tier 2 organisms. So the investigation burden is pretty low, but we do want to make sure that we follow up with these cases as quickly as possible to prevent further transmission in the region. And finally, tier 1 isolates are going to be those that are either very rare across the whole United States, or they're just absolutely awful and scary, and we want to prevent any transmission from happening as much as possible. So this will include pan-resistant isolates or other resistant bugs that we haven't yet identified but want to prevent once we do. Now I think we're going to move into a poll question.
A poll question for everyone. So let's launch the poll question for Patty's presentation. Very exciting. Let's see. Haha, it goes right along with what you were just saying. So when investigating a tier 2 case of novel resistance, we should ask about all of the following except. Patty, what are our options?
First is going to be travel history. Second is healthcare exposures. Third is penicillin allergies. And fourth is transmission-based precautions.
So what do you think it is, audience? I see we have some great comments. Poll is in progress. Give it a couple more seconds to get your answer in. It looks like less than half have voted. Oh, the number's climbing. Okay. All righty. And we're going to close the poll. And we're going to share the responses. Patty, it looks like most people think penicillin allergies is the answer.
And that is correct.
Woohoo!
So very nice, y'all. So travel history, healthcare exposures, and transmission-based precautions are pretty standard questions that we would ask in the case of an MDRO. But asking about a penicillin allergy is usually something that you do when you're figuring out how to treat a patient isn't something that's really helpful in a public health response. So that's why penicillin allergies is the only item that you should not be asking about in a case of an investigation.
Great. All right, let me let you get back to your slides.
Yeah, here, I got it.
Got it?
Oops.
There you go.
Okay, so this screen is looking a little funky, but this is just for pretty easy reference what response activities you should be looking at for each tier of organism. So as you can see, for Tier 1 and Tier 2, there are going to be a lot more response activities, including collecting that patient information, such as healthcare exposures. And then Tier 3 organisms, such as that KPC, we know a lot about these this resistant gene already, so instead of collecting additional information, we really just want to focus on preventing additional transmission. Whereas the other two tiers, we want to learn about as much as possible about these organisms. But really, what does this mean for the local health department? I think this is the biggest question that all of y'all are asking. And there are a few big take-home points for y'all today. I know that you should know, number one, that isolates from patients in your jurisdiction may be sent for further characterization and assessed for novel resistance in the near future. Two, sometimes these results will require a public health response. Now, our team at the Communicable Disease Service will always be a part of these investigations, but we do want to jointly work on these investigations with our local partners. And three, depending on what we learn from these investigations, such as finding evidence of transmission or major gaps in infection control, we might need to do a site visit at the facility. Now, this isn't something that I really spoke on today, but as you know, with most other communicable diseases, on-site assessments at a facility can really play a huge part in stopping ongoing transmission. And this is the same exact thing for CRE and other resistant bugs. And finally, the more testing that we do as a part of the ARLN, the more we know about resistance in New Jersey. So more testing can help us discover new forms of resistance, and in some cases it may show us that some types of resistance are here to stay or more or less common than we first thought. So the more we test, the better we can really prioritize investigating these threats and may eventually move some of these different genes to lower or higher response tiers as we learn more. Now, overall, antimicrobial resistance is a pretty big and scary world, and the ARLN is a huge first step for us to really understand more about resistance locally and here in New Jersey. Well, I don't really look forward to adding another disease investigation to your to-do list or to mine. Learning how to really quickly respond to these threats now in these more routine cases will help make sure that when we do identify that first pan-resistant isolate in New Jersey or that next big scary Tier 1 bug, we really are able to stop it in its tracks and keep our local communities safe as quickly as possible. Now, I think we're going to hold all questions to the end, but if you guys could go ahead and put any questions that you have for me in the chat, we'll be going over them at the end of the presentations. And I thank you for your time.
Thanks, Patty. That was very interesting, very relevant to every day.
Thank you so much. That was great presentation. Our next speaker is Kathleen Ross, and she will give us update on Candida auris.
Wow.
Welcome.
Thank you, Laura. Patty's presentation was so good, so it's going to be hard to compete with, but I'll do my best. All right, good morning, everyone, and thank you for the coordinators for having me this morning. So today we're going to be talking about Candida auris in New Jersey. First, I'd like to acknowledge that today's materials are an update from Patty's presentation earlier this year, which you might have seen. Additionally, I'd like to acknowledge that some of the content has been adapted from other presentations given by our colleagues at the CDC. So if they are ever listening to this presentation, thank you guys. A quick overview of today's agenda. There will be a brief review of the basics that were discussed by Patty earlier this year. We'll explain why there is a concern for Candida auris. We'll provide a national and local situational update. You'll hear about some of the public health efforts that are being taken to prevent transmission of Candida auris and what public health partners can do to help. So, to quickly refresh your memory, Candida auris is a huge genus of yeast that is ever expanding as we learn to identify more organisms. Historically, when people think about bloodstream infections and other Candida infections, they think of Candida albicans. However, today, less than half of Candida infections are caused by Candida albicans. And today, we'll be focusing on the new, emerging Candida species, Candida auris. Candida auris was first described as a pathogen in 2009 when it was isolated from a patient with an ear infection in Japan. Fun fact, auris is the Latin word for ear. Despite its name, Candida auris can also affect many other regions of the body and can cause invasive infections, including bloodstream and wound infections. Retrospective review of Candida strain collections found that the earliest known strain of C. auris dates back to 1996 in South Korea. Candida auris has been recognized as an emerging pathogen worldwide because of the increasing number of infections that have been identified in multiple countries since it was first recognized. In June 2016, the CDC released a clinical alert requesting that clinicians, lab techs, infection preventionists, and public health authorities report C. auris cases. 2 months later, CDC reported that the first 7 U.S. cases of infection have been reported. 6 of these cases occurred before the clinical alert in June and were retrospectively identified. So, who is at risk for infection from Candida auris? Patients who have previously received antibiotics or antifungal medications, patients who are immunocompromised, patients who have indwelling devices entering their body, and patients who have been hospitalized in healthcare facilities for a long time appear to be at highest risk of infection. Further research is still needed to learn more about risk factors for C. auris infection. So, why are we concerned about Candida auris? First, there are many challenges in the identification of C. auris isolates. The isolates are difficult to identify with standard lab methods. Identification requires specialized methods. Without, isolates can be misidentified as other Candida species, leading to inappropriate management. C. auris can be misidentified as a number of different organisms when using traditional biochemical methods for yeast identification. Notably, in New Jersey, Candida auris has been reported to be misidentified as Candida hemolonii by commercial identification systems such as Vitek2. Another reason for concern is that Candida auris can cause serious infections. C. auris can cause bloodstream infections and even death, particularly in nursing home patients with serious medical problems. More than 1 in 3 patients with invasive C. auris infections die. However, many of these patients had other serious illnesses that also increased their risk for death. Further research is still needed in this area. Not only can Candida auris cause serious infections, but it often does not respond to commonly used antifungal drugs, making infections difficult to treat. Unlike antibiotics, there are only 3 major classes of antifungals in the United States, meaning that even small levels of antifungal resistance can severely impact treatment options. One of the most alarming characteristics of this outbreak is how difficult it can be to control despite intensive infection control efforts. Patients can remain colonized with C. auris for a long time, and C. auris can persist on surfaces in healthcare environments. C. auris can spread in healthcare settings through contact with contaminated environmental surfaces or equipment, or person-to-person. Environmental testing has shown that areas surrounding colonized patients can be extensively contaminated. Quaternary ammonium disinfectants, which are widely used in the healthcare settings, are not effective against Candida species. And there are no known colonization regimens for colonized patients. Information is limited on the duration of C. auris colonization. However, evidence suggests that patients remain colonized for many months, perhaps indefinitely. CDC currently recommends continuing contact precautions for as long as a person is colonized with C. auris. Patients that are colonized with C. auris can be rescreened every 3 months to help inform duration of contact precautions. If a patient's rescreening swabs are negative, then at least one more assessment at least 1 week later is needed before discontinuing contact precautions. So what's going on in the United States? As of October 31st, 2017, 369 confirmed cases of Candida auris have been reported to the CDC. That includes 157 confirmed clinical infections and 212 colonized patients. For reference, clinical cases are based on cultures from specimens that are collected for the purpose of diagnosing or treating disease during the normal course of care. So this can include cultures of body sites reflecting invasive infections, such as the blood. Cultures of wound, urine, and respiratory tract could also be classified as clinical cases unless the lab report indicates that the culture was collected as part of screening or surveillance and not in the normal course of care. Then we also have colonized cases. Colonized cases mean that these patients are found to be carrying C. auris even though they are not sick with infection. Many colonized cases are identified during targeted screening efforts, which is part of an effort to control the spread of C. auris. Colonized cases are based on specimens collected for the purpose of screening or surveillance. Specimen sites can include the skin, external ear canal, nares, rectum, stool, or other external body sites. Cultures collected from other specimen sites, such as urine or respiratory cultures that are collected specifically for screening or surveillance, will be classified under this colonization classification as well. Additionally, the CDC reports that there's been 29 probable C. auris cases that were retrospectively identified. This means that these patients were identified to have Candida hemolonii from a normally sterile site and are from healthcare facilities with other known C. auris cases, but the isolate was not available for specialized testing. So this is a U.S. map that can be found on the CDC website. It shows clinical cases of C. auris reported by state as of October 31st, 2017. As you can see, most C. auris cases have been identified in the New York City area and New Jersey. So as of December 4th, we have identified 139 Candida auris cases in New Jersey. This includes 61 clinical cases and 78 colonized cases. So based on what CDC has learned from colonization screening, we've been actively working to detect unidentified colonized patients in New Jersey. What we've learned from these investigations is that most of these patients are severely immunocompromised and are at risk for all sorts of HAIs. The C. auris cases have multiple epilinks from equipment, the staff, and specialty care, and many times there's overlap in unit locations within healthcare facilities. The facilities that we identify that have C. auris patients tend to be those with longer length of stay and high acuity, such as vent or ICU type units. And many of these cases have multiple healthcare exposures and are transferring between facilities. The facilities that are all affected with C. auris cases are highly connected in what we call a transfer network. So the patient will go from a hospital to an LTAC to a long care facility, and then they might be readmitted to a hospital within this network. So what are we doing to contain C. auris in New Jersey? Single cases of Candida auris should be reported to public health for further investigation. Our team has created a Candida auris case report form, which is used to identify healthcare exposures, link cases in place and time, and helps us to characterize C. auris. We identify all healthcare exposures in the previous 90 days to notify them and provide infection prevention recommendations. When patients are transferred, we ask to be notified so we can notify receiving facilities and ensure that staff are aware of infection prevention recommendations. And depending on the situation, we may offer surveillance testing. When we identify a colonized or infected patient who is in a healthcare facility without proper contact precautions in place, we typically recommend screening close contacts, such as roommates. Screening of Candida auris is done using a composite swab of the patient's axilla and groin. These two sites appear to be the most common and consistent sites of colonization. If we suspect that C. auris transmission is occurring in a facility, we will strongly recommend a point prevalence survey where all patients on a specific unit or floor will be screened. And some facilities that have ongoing transmission do conduct regular point prevalence surveys to ensure colonized patients are quickly identified and placed on appropriate contact precautions. The cost of point prevalence surveys is footed by ARLN, which Patty mentioned in the earlier presentation, and the costs are footed by the CDC. So this includes the screening supplies and shipping fees. And CDC will also support facilities that are interested in rescreening known colonized patients. Laboratories with the capability to characterize isolates further encouraged to do so, but if they don't have a reference lab, CDC and some state and regional public health labs are able to assist with further characterization when that local capacity does not exist. So, what guidance are we providing to healthcare facilities in the state? Back to the basics, patients with indwelling devices are at higher risk for Candida auris infection. So basic infection prevention by maintaining devices and removing whenever possible can reduce risk of infection. A big piece of this can also include targeted education for those specialists who are caring for these devices regularly. We know a major concern with C. auris is that it can persist on surfaces in healthcare environments. So products that are routinely used in healthcare facilities are shown to not be effective against C. auris. Until further information is available, CDC is currently recommending use of a EPA registered hospital grade disinfectant, which is effective against C. diff spores. It is important for healthcare facilities to follow all of the manufacturer's directions for use, including applying the product for the correct contact time. We also recommend thorough daily and terminal cleaning and disinfection of the patient's room, and cleaning and disinfection of the areas outside of the rooms where they receive care. So examples would be radiology or physical therapy. These activities are necessary. Shared equipment such as ventilators or physical therapy equipment should also be cleaned and disinfected before being used by other patients. Colonized infected patients can both be a source of C. auris transmission. These patients should be managed using standard and contact precautions. Diligent hand hygiene and gown and glove use is a must whenever entering the patient's room. Patients with C. auris should be placed in single rooms when possible. Patients with C. auris could be placed in rooms with other patients with C. auris. Patients colonized with C. auris and other MDROs can be placed in rooms with patients colonized with the same MDROs. CDC does not recommend placing patients with C. auris in rooms with patients with other types of MDROs. To the extent possible, we recommend that facilities minimize the number of staff who care for C. auris patients. If there are multiple C. auris patients present in a facility, they can consider cohorting staff who care for these patients. And I believe the next slide is a poll slide.
Poll question.
Thank you, Laura.
All right. Woo-hoo. All right. Let's go. Ooh, we just talked about this one. So Kathleen, it says, when can a patient who is colonized with C. auris be removed from enhanced contact precautions? And your answers that you provided for the crew are after one negative skin surveillance culture, when they're moved into a private room, 24 hours after starting treatment, or after 2 consecutive negative skin surveillance cultures. So go ahead, everyone, and vote. What do you think the answer is? All right, it looks like we have a little more than half of you voted. I'm going to keep the poll open till we get to at least 70%. Oh, wow. Very interesting. Okay, I'm going to close the poll and show the responses. Share. Kathleen, it looks like everyone thought the answer was after 2 consecutive negative skin surveillance cultures.
You guys are good.
Ha-ha!
I'm impressed.
All right, well done, everyone. So we'll go back to the rest of Kathleen's slides. There.
All right, so duration of infection control precautions is a difficult issue because as far as we know, Many patients remain colonized with C. auris indefinitely and continue to shed the organism. Our team at the health department and CDC support colonization rescreening for known cases every 3 months, and after 2 consecutive negative cultures, we support removal from C. auris level precautions. I do want to reiterate that these infection control measures should not limit necessary clinical care or patient transfers. We're always here to work with the receiving facility to determine how to implement appropriate contact precautions without implementing patient care if a receiving facility is hesitant to receive a C. auris colonized patient. Many C. auris patients in New Jersey are what we consider frequent flyers, so ensuring that every receiving facility is aware of a patient's status is very important. Our team has developed a communication form that should be included with the patient's paperwork when being transferred. We do ask that healthcare facilities let us know when and where a patient's being transferred so we can review all the infection control recommendations with the receiving facilities. So speciation of Candida is a very important first step in identifying C. auris. CDC released a clinical alert a couple of months ago, and they're currently recommending that healthcare facilities and labs test all Candida isolates obtained from the bloodstream and other normally sterile invasive body sites to determine the species. Healthcare providers should also consider testing Candida isolates from non-sterile, non-invasive sites to determine species in certain situations. So examples would include when there's a known C. auris patient in the facility or recently passed through the facility. The patient in question has reported healthcare exposures in another country where C. auris has been reported, and of course when clinically indicated, such as no response to initial therapy. Additionally, facilities should monitor for changes in overall number of Candida species identification or infection taking place. Additional infection prevention recommendations for other settings can be found on the CDC's website at the link below. And of course, we ask that all cases be reported to our team at the state. We share case information with CDC, but do need this information to quickly follow up as soon as possible with any facilities. Online, the CDC has many resources available for various audiences, from the public, the healthcare providers, to the folks in the lab. We're continuing to work with their team to add additional resources based off questions we tend to receive from facilities and patients. Now, in summary, Candida auris can cause deadly clinical infections. The organism is difficult to identify, is drug resistant, and can spread easily in healthcare settings. The control breed C. auris, we need to ensure proper identification and response to the organism. And fortunately for us, New York and New Jersey have been hit the hardest with transmission. So thanks to all the folks that are working on C. auris at the state, local, and national level. Thank you.
Wonderful. Thank you. Thanks, Kathleen. Oh, so again, if you have any questions, please put it in the question box. And we will have Kathleen address your question at the end after all presenters have gone. So we're getting ready for our third presentation this morning. Sharif?
So I guess this presentation, we all been waiting for it. So our influenza expert, Lisa McHugh, will give us overview and update on the 2017-2018 influenza season.
Perfect. Thank you, Sharif, for that introduction. Thanks, everybody, for being on the call this morning. I hope we're conveying some really great information to you. So as per normal, I'm usually tasked with, in the fall-winter season, of providing an update for folks. And so that's what I'll try to do. And I've received some questions through the Regional EPI program, and I'll so just some overview of the goals of our respiratory virus surveillance program here at the State Health Department. It's really to track spatial and temporal spread of respiratory viruses so that we can inform our clinical community about treatment and infection control. We want to try to describe clinical infections, track epidemiologic changes, and determine groups at highest risk, as that can sometimes impact guidance for our public health recommendations. Clearly, to monitor illness severity so that we can determine if we are in fact having a quote-unquote bad season, to detect unusual events, and certainly to monitor outbreaks of disease. So when we talk about influenza surveillance, our numbers are really just an estimate, and that's really because we cannot count every case of disease, and what we count is really only a portion of the true influenza burden. We can count those that are seen by a physician who've been hospitalized or have died in some circumstances. And even within the yellow circle that's highlighted on the slide, we do have some tracking, is because, sometimes what is and is not seen as influenza, or what is tested, is not always necessarily reported. And certainly those at the bottom of the pyramid, those that are cared for at home and never seek any care, and those who may not actually have symptoms of influenza and may not be reported, are not something that we can easily track. So as I've mentioned, it's impossible to count all cases of influenza, and so we use something as a proxy, the influenza-like illness. Our definition is very broad, and you can see the definition here, which is fever and cough and or sore throat in the absence of another known cause. So when we use this for surveillance, it's really possible that we're picking up other respiratory illnesses, not just influenza. And so in order to characterize which of those cases are actually influenza, we combine it with other more reliable data, such as laboratory data, and use that as a proxy. And we gathered that data from a number of different sources, which I'll talk about. And again, the limitation of this particular definition is that we are casting a wide net, therefore picking up other things that are not influenza, which is why some of the non-influenza surveillance that we've been conducting most recently is important. So if we look at how we look at graphically the way that some of the information that I've just presented to you, here you can see that if we look at ILI, which is the orange line, and we match that up with other laboratory data, which is much more specific. So here you see things like rhinovirus, respiratory syncytial virus, or RSV, influenza A and influenza B. We can see the different peaks within the ILI curve are matched by some of those that are from the laboratory data. And so this is kind of how we use multiple surveillance systems to give us a better picture of actually what's going on. So in general, there are three primary components to our influenza surveillance system: data we get from the laboratory, information we collect on influenza-like illness, and then certain disease-specific components. As far as laboratory data, we get cases that have actual positive laboratory results. With those laboratory results, we often get basic clinical and epidemiologic information. And this allows us to look at both the type and the concentration of specific circulating viruses, specifically like influenza. So you have H3s and H2s and Bs, or H1s and Bs, excuse me. And this information is reported from multiple sources. Just a reminder that influenza laboratory data is actually a reportable condition through 857 New Jersey Administrative Code. Positive influenza laboratory reports are required to be reported into CDRSS. And this kind of varies based on the connection within certain laboratories. So for those laboratories that are connected to CDRSS through ELR, or electronic laboratory reporting, must report all positive influenza cases. That includes those that are rapid, PCR, or culture. And we also request that they actually aggregate their rapid data in the ILI module, and I'll show you what that looks like in a few slides. Those laboratories who are not yet connected via ELR, who are quote-unquote manual entry of those laboratories, we request that they enter culture and PCR data, but only aggregate the rapid data in the ILI module. So they do not need to hand enter individual rapid data into the actual CDRSS system. We also have a system of Sentinel laboratories within the state. The State Public Health Lab, PHEL, can test for seasonal and novel influenza viruses, and they can do that free of charge. We also work with several Sentinel facilities, predominantly located within acute care facilities, who submit 3 to 5 positive specimens to the State Public Health Lab for additional testing each week. Despite having some of these Sentinel facilities, we really encourage all facilities to try to submit specimens, especially when they're experiencing outbreaks or there's other cases that are of significant concern. The State Public Health Lab is currently working on influenza B lineage testing, and we hope by the end of this season that we'll actually have that up and running, and so you may start seeing that within CDRSS. And then a subset of everything that's tested at the State Public Health Lab is sent to CDC for antigenic characterization and antiviral resistance testing, and this is useful to determine vaccine effectiveness. So this is just a screenshot of what the CDRSS system looks like. So this is the ILI module. And you can see here that individuals, both at schools and long-term care facilities, can access their own data, enter their own data by having a user account within CDRSS. Folks from schools and long-term care facilities are limited just to access in the ILI module. They don't see the other case data that you and I might actually see if you're listening in from a local health department. So as far as influenza investigations, influenza AH3, H1B, and 2009 H1N1 are all entered into the CDRSS system as confirmed e-close if they're coming from ELR. If they're manual entry, often you will see them as RUI pending, although sometimes some acute care facilities put them in as something else. And again, there's no investigation needed on influenza cases. They can simply be closed out. There are a few exceptions, and I'll talk about them on the next slide. Again, if they are ELR reported and they are a novel influenza, essentially AH5 or AH7, they will go into the system as RUI pending, and these do require investigation. So the only time a local health department would need to conduct an influenza case investigation is if it does meet our pediatric influenza case definition, which is any child less than 18 years of age admitted to an ICU or the child has died. We have guidance both on our website, and there was a links message sent out prior to the season starting. Case investigations also need to be conducted if there's a lab report indicative of a novel influenza strain. Again, this could be an H5, an H7, or something that comes in that says A unsubtypable. Case reports that are in CDRSS that do not fall into one of these criteria do not need to be investigated by the local health department. Pediatric influenza. So just to highlight and go into that in a little bit more detail. So what you're seeing on the screen, and I'm not going to read through this, is the actual case definition. So these are the cases that we are specifically looking at collecting. But occasionally what can happen is that in CDRSS, we get lots of laboratory reports for kids less than 18, but often we don't know if they've been admitted to an intensive care unit. So there sometimes does need to be some additional follow-up with the acute care facility on these cases. The good thing is that there are a limited number of facilities that do have intensive care units for pediatrics in the state of New Jersey, and we know who they are, and we do have fairly good relationships with those facilities. And so the follow-up really is to determine if the child has been admitted to an ICU or has died, and if so, there is a survey that attaches to the CDRSS record. We ask that you work with the facility to complete that survey, and then also additionally update that case with information such as discharge data or treatment when the child is finally discharged from that facility. If the child has not been admitted and has not died, just note that information in CDRSS so that we don't have to do additional follow-up, and the case can be closed as confirmed LHD closed and finally DHSS approved. As far as other types of influenza-like illness surveillance that we conduct, we do look at information from emergency departments, both ILI visits and admissions, and this data comes directly from our epicenter system, which is the syndromic surveillance system that is used by the state health department. This data is entered directly by NJAC staff directly into CDRSS, so local health departments, while you can view this information, you do not need to worry about any of the data entry. As far as school absenteeism and ILI and long-term care facilities, we have worked and partnered with many schools and long-term care facilities. They are provided a direct username and password into the CDRSS system, and they go on weekly and enter their information. So the total census of that school and the number of students absent, or the total census in a long-term care facility and those residents reporting with influenza-like illness. This is extremely helpful in looking for outbreaks and also to tell us what's happening in kids and what's happening in our older populations. And again, there is no limitation on who can participate. Any locals who have any facilities or schools that they would like to participate in this surveillance program, you can just reach out to our program here at the State Health Department, and we're happy to help you register those individuals. Additionally, there are some CDC systems that are available for influenza-like illness that many folks in our state participate in. One is ILI, which is the United States Influenza-like Illness Outpatient Surveillance Network. And this is actually something that we recruit individual providers. We have a lot of local health departments who also work with us in this. And the data is actually reported directly to CDC through their website, and then it's downloaded here weekly by the state health department. Additionally, deaths are monitored through the National Center for Health Statistics vital stats data, where death certificate data from state vital stats offices are reported to the CDC. This is actually looking at deaths associated with pneumonia and influenza, and there is a pretty significant time lag in this data, so sometimes it can be several weeks back before we actually know all of the information about those cases. Influenza-like illness surveillance. So there are a few special projects that we have participated in the past. One of them is our Influenza Incident Surveillance Project, or IASP. We were one of 13 states who was participating in this project, where we would involve a few providers, and they would essentially serve as enhanced ILI net sites, both providing a significant number of specimens to the state public health lab, as well as very detailed clinical and epidemiologic information. We've subsequently lost that funding due to budgetary cuts at the federal level, but some of our providers continue to participate in an enhanced surveillance way by providing some of that continued information. Other ways we look at influenza-like illness is through long-term care facility outbreaks. Our regional EPI program does a great job of handling many of those and collecting great information, and the locals do a great job in working directly with the facilities, so thank you for doing all of that. And then there's epicenter anomalies in which we track respiratory or influenza-like illness anomalies through our epicenter syndromic surveillance system.
And it looks like it's time for another poll. Woohoo! Yay. The fun just never ends. Let's see. So Lisa has a question for the polls about influenza surveillance. And her question says, when should reported influenza cases be investigated by the local health department? And Lisa, your options are?
Never. If a child younger than 18 is admitted to the ICU. If a novel influenza case is reported, or B and C.
So it looks like we have started our voting. So pick an answer, any answer. We have about almost 50% of you have voted, so keep it coming. This is a fun, interactive way to learn. Surveillance for everyone. Yay. All right. So it looks like about 70% of you have voted. So we're going to close the polls in about 5, 4, 3, 2, 1. Let's close. Let's see what we get for our results. Lisa. Most people said B and C, 86%.
Well, Laura, that is correct. So B and C. So again, if a child is younger than 18, is admitted to an intensive care unit, or if a novel influenza virus is reported. So those that reported B, if a child is younger than 18, is actually true. But if it's a novel virus, it also needs to be investigated as well.
Wonderful. Thanks, Lisa. And we'll get you back to your presentation.
Terrific. So next we're going to just talk briefly about outbreak guidance, and I'm not going to go into a lot of great specific details. I just want to highlight that I hope you know that we do have very specific outbreak guidance documentation on the state public health website. I know that there's been some redesigns in the state public health website, so sometimes things are a little bit difficult to find, so I've included the web link at the very bottom of this slide. I don't think this is new to anyone, but all outbreaks are immediately reportable. School and daycare outbreaks, we occasionally have some things that get reported to us as outbreaks that we have recently started calling investigations, and that's really kind of situations that we're watching to see if they turn into outbreaks. They're treated very similarly to outbreaks, except we just kind of don't want to go through all of the work and making you do all sorts of outbreak reports if in fact it's just kind of watching in a school or a daycare if something actually develops. So I just wanted to mention that in case folks have heard that term being used recently. So again, as we move into the flu season, I would highly recommend that you review the guidance documents for outbreak criteria and response. Just a few reminders is that one confirmed influenza test plus influenza-like illness in a long-term care facility does make a confirmed influenza outbreak in that facility and does warrant antiviral treatment and prophylaxis to be provided to all residents of that facility, not just one wing, not just the roommates, the entire facility, and that is something that will be stressed by your regional epidemiologist. Exclusion criteria for schools, again, we typically recommend 24 hours of a child being fever-free without fever-reducing medications in order to return to school. So just moving on quickly to non-influenza surveillance, I think as you've probably mentioned me saying before, it's really challenging as we cast a wide net for influenza-like illness because we are picking up other respiratory viruses. And so some of our non-influenza surveillance methods that we've been getting into more recently is really trying to ask the question, if it's not influenza, what is it? And so we're trying to use our non-influenza data to kind of better answer that question of when we start to see increases in respiratory diseases, if it's not flu, what kind of viruses are we dealing with, and can we help provide some recommendations and public health control measures surrounding that? So just some of the non-influenza surveillance that we're doing. Respiratory syncytial virus has been around for quite some time. We've been doing this surveillance for probably about 10 years now or greater. This is where the number of positive tests and the number tested by many acute care facilities are reported into that CDRSS ILI module that I showed you earlier. Again, that's entered directly by the facility laboratories. We have a system called NERVS, which is the National Respiratory and Enteric Virus Surveillance System. Again, this is a CDC system where we recruit acute care facilities. These facilities report influenza plus 6 non-influenza viruses. Again, it's all based on testing and test results. Again, these facilities report directly to CDC, and then we actually download that data from a CDC website. Additionally, the State Public Health Lab has, within the last few years, been bolstering their respiratory virus panel testing. Our test actually tests for influenza and 5 non-influenza viruses. We actually use an algorithm to select certain specimens through our routine respiratory specimens that are sent to PHEL. It's not possible with our funding allocations to test every single influenza negative influenza test that comes to the State Public Health Lab, but our algorithm works pretty well at identifying the subset that might be occurring. And then certainly we can use this panel on any types of outbreaks that might be occurring when we think that influenza has been rolled out and there's a possibility of other non-influenza viruses causing that outbreak. So I hope you all have seen this. This is the new influenza report. We've changed the look a little bit. Again, it's been in a different location on our website. So again, I've listed the website at the very bottom for those of you who may not be seeing this. Again, the report gets sent out both through the link system and is posted to the website, usually by close of business on Wednesday. So just a few additions to the report. Again, I've talked about how we are trying to bolster some of our non-influenza surveillance data, laboratory data that we're doing. So we've started sharing some of that information so that you can kind of see, kind of what viruses are out there that aren't flu. And again, we hope that over time, as we begin to bolster our non-influenza surveillance data, we'll be able to share more and more information as time goes on. Of course, novel diseases have not gone away. I've kind of figured that many folks were probably tired of hearing about MERS and novel influenza, but just a reminder that there are still cases of many of these being reported, H7N9 in China, H5N1 in Southeast Asia, and H3N2V, which is the variant swine influenza virus associated mostly with agricultural fairs or events. Are still occurring. We do have guidance on our website. And again, if you're having issues navigating our website, I've included the link here. And then MERS still continues to be a thing, with the majority of cases continuing to occur in Saudi Arabia, although there does continue to be an occasional travel-related case in other countries. And again, we do have guidance on our website regarding that, and that is the link associated with MERS cases. So this has been the million-dollar question that's come across my desk in the last few weeks. You'll notice at the top left, I have a crystal ball. Many of you who have known me as an influenza surveillance coordinator have known that when you say to me, how bad is the flu season going to be? I would say if I knew that, I would play the lottery more. What we know about influenza is that influenza is unpredictable, and it's really too early in the season for us to determine what type of season we're going to have. It's also too early for us to determine vaccine effectiveness. There have been some reports out from Australia that their vaccine has only been about 10% effective. And from their vaccine effectiveness studies, that is true. However, in the past, CDC has seen that our vaccine here in the United States has been somewhere between 32 and 39% effective. And so the virus appears to be similar based on early indications of what strains have been circulating. And so the CDC anticipates that we probably will see some type of similar vaccine effectiveness here in the United States, although it's really too early to tell. The first vaccine effectiveness study results typically come out sometime in February, where we'll be able to have a little bit of a better idea of how effective the vaccine actually is. What I can tell you is that the viruses that are currently circulating do appear to actually match the strains that have been selected to be in the vaccine. So that's always a good thing, meaning there's not a mismatch in the vaccine. And so we'll continue to look closely and wait closely on what's going to happen. We are starting to see increased flu activity here in New Jersey. We just increased the level this week for additional activity. We are now up to moderate activity. There are a couple of regions within the state that are actually at moderate activity, and we are seeing an increased amount of influenza B. This is pretty early for influenza B in a typical season, but we're also seeing H3N2. We're also seeing increases in RSV, which is very typical for this time of year as well. And that's all that I have for you. Thank you.
Thanks, Lisa.
Thanks, Lisa. That was really interesting. We are hoping for a reasonable influenza season. We always leave our best for last, and our last topics with it will be on hepatitis B and C surveillance with Dr. Laura Taylor.
Thanks, Sharif. Thanks. I just wanted to point out, you do have extra slides from Lisa McHugh's presentation. She wanted to include a couple extra charts for your viewing pleasure. So in case you're wondering what those extra slides were, she just wanted to provide additional information. Before I begin with the last presentation, I'm the only thing standing between you and credits. I wanted to let you know that we have reached out to NJLMN and we have not heard back from them yet. So we let them know that the system is down. But again, if you are watching the webinar and were unable to register on NJLMN, please send me an email and I will make sure that you get the evaluation. So it's laura.taylor@doh.nj.gov, and I will be sure that you are taken care of as far as credits go. So that was just an entry statement. So thank you, Sharif, for letting me present. This is going to be quick and lovely. I don't want to say dirty. It's too early in the morning to be dirty. But we wanted to share with you a new grant that we received here at the state, and then how that may impact what the locals are seeing. So we received a hepatitis B and C surveillance grant earlier this year, and we kind of just wanted to give the locals and our other healthcare partners an overview of what's involved with that grant and how it may impact you. So we received a cooperative agreement to support and improve surveillance of acute and chronic Hep B and C. We're very excited because this provides more opportunities for us to strengthen what we're currently doing. And as you know, CDRSS is going through a redesign, and some of the contents will be included in the updated CDRSS redesign for hepatitis B and C. So this was a competitive 4-year cooperative agreement. So we'll be working on this particular project for the next 4 years. There were a total of 14 states selected to participate in core activities, and New Jersey also applied for and was awarded optional funding. Really interesting. It's all interesting, but you know, there we go. So this is basically what we are tasked with as part of the surveillance grant for the core activities. So you can see they're looking for us to incorporate that new CSTE case definition for Hep C that also includes perinatal Hep C. So in case you didn't all participate and listen to the webinar that we had back in November about the new case definition and case classification of Hep C, that is posted on the New Jersey Department of Health website along with the new guidance and the slides. So you may watch it or you can follow along with the slides. So I would encourage you, if you haven't watched it, it was very well done. Bernice Carr, by our hepatitis C epidemiologist, did a great job. And again, now we're going to begin collecting, as of January 1, information about perinatal Hep C. So increasing the case surveillance data, using other data sources. So the CDC is very interested in having us look for new acute cases. That's the big push. So we're going to be looking at other data sources that we use here at the state, including breakfast data, electronic birth certificate data, where we can possibly find more cases and get more complete data about those cases. We're also going to develop and maintain a registry of Hep B and Hep C cases. We already currently do that, but maintaining them and making sure all the information is up to date and current and correct. And I'll get to more about that later. Develop and share surveillance data with the CDC and with you, our partners. Detect and investigate outbreaks, and develop technology to improve surveillance. So the big thing that they're looking at is case completeness. So the CDC is really looking to define more of the burden of hepatitis B and C in this country. So they're more interested in having information about who is getting infected. Is it an acute case? Is it a chronic case? And what are the risk factors? So more on that comes soon. We are also going to continue with our ELR, electronic laboratory reporting. In New Jersey, we have approximately 95% of all cases transmitted via ELR, and we receive over 65,000 cases in case reports in 2015 through ELR. So we are looking to continue getting these cases reported through ELR. The 12% that we do not receive through ELR are entered by the laboratories and are mostly Hep C cases. And so we're already meeting their goal of having more than 80% of laboratories transmit this data. However, our goal is to have even more. So that 12%, we're looking to make it as high to 100% as possible. We have high goals for ourselves. So we're also incorporating external data sources to, again, determine the true data, the true burden of Hep C, and increase the knowledge of hepatitis B and C among prevention programs, which kind of plays into the optional program. I'll talk about that later. And then reduce cases of Hep B and C due to interrupted transmission and identified outbreaks. I think this is the rationale between really actively looking for acute cases so we can stop that transmission when it's still in the acute phase. So we can identify outbreaks, find out where the issues are, and hopefully stop the chain of transmission. So this is what the CDC is looking for. These are their outcomes that we've been tasked with for 4 years. So in the CDRSS case report, what they're looking for is 90% completion for age and gender, 70% case completion for race and ethnicity, 60% case completion for county and zip code of residence, 50% completion for source of testing, and 70% for complete risk information. So we are currently pretty good for age and gender, county and zip code, and for race and ethnicity. No. You know what? I'm going to step back and actually read my slides for a moment. For some variables, New Jersey is ahead of national goals. So for gender, age, zip code, and lab testing, we're at about 95%. However, for the other variables such as race and ethnicity and source of testing, we're not. we're a little far behind. So these are the variables that we are going to ask you as the locals when you're completing your investigation forms and when you're entering information about cases in CDRSS. Can you please make every effort to complete these particular fields? Because the CDC is really looking at these when we send down our information via transmission. This is what they're looking for. And those of you who participated in the new Hep C webinar saw the new CDS 17 form, which includes the risk factors that we're looking forward to completing.
I'm almost done, I think. I'm almost done.
Okay, so other activities that we're going to have for case completion, I think I mentioned early the EBC data, electronic birth control data for Hep B and Hep C positive mothers. You know, since we're now looking at perinatal, this will give us more information that we've had in the past. We're also looking at our STD cases that are currently in CDRSS. You know, they do a great job with their disease investigators, so we are going to piggyback on their data, and hopefully that will help us get more completion in our external data sites listed here. And then our subject matter experts will monitor cases and reach out to folks who we will request to have a better case completion. And then again, the new CDS 17 form should help you when collecting data when you do your investigations. So these are some of their surveillance outcomes. So we have a new hepatitis epidemiologist, so for Hep C, Bernice Carr, but we also have hepatitis epidemiologist for Hep B. Allison Portney is on this project as well. And so she and Bernice will be analyzing the trends from what they see from the Hep B and C cases by county and by region. And this is to help to identify if there's outbreaks and recognize any other trends that we're seeing. Investigation of local health departments of priority populations will help identify, I believe in the Hep C webinar, we did give those priority populations where we recognize in some jurisdictions Hep C is overwhelming and the amount of cases is exorbitant. And obviously we can't investigate everything. We just don't have the resources. Again, if you have the resources, we are happy if you investigate them. But if your resources are limited, we did identify some priority populations for you to focus on. And those are in the guidance that are also posted on our website. So as far as case completion goes, we're asking the local health departments to complete the CDRSS case reports for Hep B and C cases, again, in these various components. So again, we're really good with many of them, but the race and ethnicity and source of testing, not as high as we'd like it to be. And again, we have 4 years to be fabulous, but why not start now? So CDC's priority, again, is acute cases. So we're hoping to really find these acute cases as we tease out the investigation. So I wanted to talk to you about a few activities that are currently going on that you may or may not know about. So we currently are working with the SENSA group, which is the Suburban Essex County Nursing Supervising Association, to increase our case completion for hepatitis B. So this is a pilot project that we started last year, in essence, to really have case completeness for household and sexual contacts of Hep B cases. And we are working with 11 municipalities and 1 private physician practice. And it's a 1-year pilot, which started back in May, so it will finish up this spring. And so we're trying to determine if increased case completeness and education activities for contacts will promote increased vaccination for Hep B among, again, those household and sexual contacts and linkage to care for those contacts. So this is kind of an interesting pilot that we started, and we're very excited to get some more data back from our SENSA partners. With the suburban folks out there at SENSA. wonderful. And we developed 5 different brochures that kind of touched on different aspects of hepatitis B. So we have one for sexual contacts, we have young adults who are infected with hepatitis B, so we have a nice array of materials, and we translated them into 5 different languages that the folks up there told us were most prominent in their county, and we distributed these materials to them in May and ask them to report back to us about the effectiveness. Once the pilot has concluded, we hope to figure out which materials were the most effective and then have them posted to our website, and also determine if we need to translate into more languages. So the folks who are helping us with our pilot have been providing us quarterly data about how many of the materials they've used, also about the referrals for care. It's also our intention to get a list of linkage to care options to provide to folks. So in the event that they need to link someone to care, they have options and places where they can send them. So again, once the pilot concludes next spring, we hope to determine which materials were most useful and post those. Also determine if we need to get things translated into more languages, which again, our vaccine preventable program paid for the translation, so thank you. And then we plan to run case reports to determine completeness. So was this initiative effective in helping link the contacts to care, to get vaccination? We're also working with our vaccine preventable program to see if there's an increase in Hep B vaccine to that area through our Vaccines for Children, which also includes adults. Again, get a list of linkage to care treatments for vaccination and treatment. The nice thing about B is that it is preventable with just 2 shots. 3 shots, we can, prevent it, which is really the key. So very exciting stuff going on for Hep B. Here is our hepatitis C, new case definitions and guidance. You can see this is taken from the webinar that was in November. So again, we have new case definitions where we're including perinatal as well as part of that case definition, which we did not do before. We have a very detailed case guidance document that includes algorithms and laboratory test information and new investigation forms. And again, this guidance also identifies priority groups for investigation. So if you have not had a chance to read it, we strongly recommend that you read it. This new case definition, we will begin collecting and using this information January 1, 2018. So those priority populations that I talked about were the suspected acute Hep C cases of any age. Again, the CDC is very interested in finding acute cases. Individuals less than 30 and older than 70 years of age are a priority because the rationale being if they're less than 30, probably it's injection drug use. If they're over 70, more likely it's from a healthcare exposure, quite possibly. So that these kind of get priorities. This is where we're looking at. This is where we're seeing cases, although this does not represent the majority of the cases that we do see. Perinatal means children less than 36 months old, born to a Hep C infected mother. And again, we can get this information from our electronic birth certificate, but at the local level, you'll probably have this information as well when you see the case come across and see the age of the child. Individuals who are patients in a healthcare setting, especially dialysis setting. So again, new case definitions. We're working to have everything ready to go as of January 2018. And again, I'm just going to plug the webinar again. If you have not watched it, please do. It's very insightful, very informative, and the guidance. And again, as Sharif mentioned at the beginning of the beginning of the webinar, we are creating a hepatitis C roadshow. We got a lot of comments back from the webinar. I think a lot of people their heads were spinning with a lot of the new information. I don't blame you, it is a lot. So what we decided to do was to create an interactive presentation for you where our regional EPIs will take this on the road and provide these to our local and healthcare partners with helping to classify cases correctly. So we have a lot of screenshots with a lot of, so you see a lab that looks like this, how would you classify it and why, and kind of walk you through the steps. It's going to be fantastic, and that should be ready in early 2018. Right before the CDRSS redesign takes place. So, there's a lot going to happen in early 2018, but please look out for the Hepatitis Roadshow. And again, you can reach out to your regional epidemiologist to put yourself on their schedule to have them come and give the presentation to you. Woohoo! So at this point, I think we have our last and final poll question. How about that? So it looks like, for case completeness, which of the following demographic fields for hepatitis cases is often not completed or left blank in CDRSS? So what do we think it is? Oh boy. Wow, everybody's voting. You're still out there. Yeah. Looks like we have half of the people voting. 60%. Wonderful. Keep on voting. All right. I'm going to close the poll in 5, 4, 3, 2, 1. I'm going to close the poll, and it looks like wonderful! Yay! You guys got it right. So the answer is race and ethnicity. So that is one of the fields that is frequently left blank or not completed. So this is something that we would like the local health departments, when they're doing their investigations or when they get information, to try to close the loop and complete that field. Thank you, everyone. All right. So let's go back. Oh, here we are. What are you trying to do? I'm trying to have my slideshow. This is the presenter view. We're having technical issues. Did you close the poll? Mm-hmm. Click on the poll thing again. No, I don't know where the poll thing went. Click on the red box. It says the arrow. Try that. Apparently it's technical questions for everybody. I mean, technical problems for, oh, there we go. Wonderful. So I wanted to talk to you about the optional component that we applied for and were awarded. So the component that I talked about earlier was the core component, and that is just your basic surveillance and completing the case report form so that we have a better view of who our folks are with Hep B and Hep C in our particular area. We also applied for an optional component, which we decided to pick working with opioid treatment programs, or OTPs, here in New Jersey. So we teamed up with our folks our partners over at Mental Health and Addictions, and they helped us create a very competitive application of which we were awarded funding. So this optional funding really was to collaborate with opioid treatment programs to conduct hepatitis B and C surveillance. So we are actually going to be working with brand new partners and asking them to provide us data about their patients. And the intention is to have the opioid treatment programs provide data about their clients' de-identified data, but about whether or not the client knows their hepatitis status. Have they ever been tested? Do they know? Have they been told by a doctor? Not just I think I have, but have they ever been told by a healthcare professional that they have hepatitis? Again, have they been tested? And then have they ever received treatment, or are they currently being linked to care for hepatitis B or C? And the data that's being collected will be shared with you as soon as we get some. So the data collection part does not begin until January of 2018. So the opioid treatment program may be able to provide local health departments demographic data about the case for the investigation. So we are encouraging the local health departments, if they have any questions about a case that may live at a particular opioid treatment program, if it's an inpatient, or maybe if that is the referring physician was one linked with the opioid treatment program, that they may reach out to that program to get more information, the demographic data to complete the case report. It is interesting. We did survey the 5 opioid treatment programs whom we awarded funding, and many of them say they know who their local health department is, but many have not worked in any capacity with their local health department. So I think this is a really interesting project with some cool outcomes that we could have. So just a little background, we did an RFP, a request for proposal, that we posted to the State Health Department website. And again, we coordinated it with our divisions of mental health and addiction, who at the time was the Division of Human Services, who is now part of the health department, and they were wonderful and gave us great direction. We actually went and spoke at various meetings to promote the RFP, and it was limited, though, to nonprofit opioid treatment programs in New Jersey. So there are 32 opioid treatment programs in New Jersey, but not all of them were nonprofit. So we kind of limited our pool by that parameter, but we did get a total of 9 applications by the deadline date, and we selected 5 facilities. So these 5 facilities are the ones who we will reach out to and collect this data from. Well, they're not getting a lot of money. The award is only $10,000 a year, but we're also not asking for too much. But the grant is, again, for a total of 4 years. So the opioid treatment program over 4 years will get $40,000 to complete some hepatitis surveillance and provide information to us. Again, they're providing aggregate data, not patient, no identifiable data where we can walk down the street and figure out who they're talking about. So this is a copy of the form that we are planning to send. The opioid treatment programs have already seen this, so they knew what they were getting themselves into. We have columns, and again, they just give us an aggregate number, send it back, and we will have a little bit more information about hepatitis B and C in that particular area. Now, we were very cautious with how we awarded the grants. We picked one opioid treatment program in each of the 5 regions. So each of the 5 regions has a program that was selected to provide data. So we know that the person, they're not all inpatient, and the person may live in various places. Not just the health department where the opioid treatment program is located may get more information or more inquiries, or you may see an increase in cases on your CDRSS feed, but some of the locals. So if folks live outside of the town where the treatment program is, you may also see an increase, which is really the rationale for why we wanted to tell you about this project, in case you wondered, wow, all of a sudden, I'm starting to see a jump in my hepatitis B or C cases. It's because we're actually looking for it. So many of the opioid treatment programs will use the money that we give them for testing. Others will use it for staff to provide the data resources to us. So depending on how the facility chooses to use their money, that not, again, was up to them, but this is the data that they will give us. The OTPs, however, will not have access to CDRSS, and they do not even know what that means. So the local health department, though, we can reach out to the contact person at the facility and give you information if you want to reach out directly to the opioid treatment program, but they will not have access to the surveillance program. Again, they are only giving us the data in aggregate form that we ask for on a quarterly basis. So if there's a positive case of Hep B or C and the address is one of the opioid treatment programs, they've been requested to provide the local health department with any information to help with the investigation. Because we know the local health department has the jurisdictional authority to do the investigation. And again, you may see an uptick in cases due to we are actively asking them to test. So here are the partners who were funded, as you can see, in each of the regions. So in the South, the John Brooks Recovery Center in Atlantic County. Central East region is JSAS Healthcare in Monmouth County. And again, there will be a new syringe access program in Asbury Park, not too far from the JSAS Healthcare facility. Central West is Somerset Treatment Services in Somerset County. Northeast is Straight and Arrow, which is located in Bergen County. And then in the Northwest, Patterson Counseling Center, which is located in Patterson, which is in Passaic County. So these are the partners that we'll be working with for the next 4 years. And again, most of them say they know their partners, their public health partners, but they haven't really had an opportunity to work with you. So over the course of the next couple years, we will be doing education for them about hepatitis, about motivational interviewing, on various topics for the opioid treatment programs, and again, linking them to their local health department partners. We did send them the link that's on the Office of Local Public Health's website that allows them to locate the local health department, because some of them said, I'm unaware of who my local health department is and where they're actually located, except for the one that is directly in my town. So if somebody is from another place, I don't know who to reach out to. So I gave them the link so that they can have those resources available. So again, we are going to be providing the staff at these opioid treatment programs with various technical assistance and collect more information about the PHEL population, and that is people who inject drugs. That's the politically correct term, if you will, that we are using. And again, the goal is testing and linkage to care. They really want to know if people are tested, if they know their status. Sound real reminiscent of HIV and what we did back then. If people don't know their status, they don't know that they have it, and you can't tell just by looking always. Many of hepatitis is typically asymptomatic, so they're working to get testing and linkage to care resources. And then again, we would also like to share these resources with the local health department to determine if there's an increase in testing, work with the local health department for case ascertainment, and then determine, again, the whole linkage to care. And we're defining linkage to care as, have they seen a healthcare professional for treatment of their hepatitis B or C? So again, it's a 4-year project, and we'll keep you up to date with anything that we find. And thank you very much for your time. And so at this point, I think we'd like to have questions. We've received a lot of questions. So Patty, Kathleen, Lisa, and we can still take more. So we've been writing down the questions, and I think we have some answers for you. So with our remaining time, come on up, and you want to read the questions and what responses you would give our folks on the line.
So, hi everyone, this is Patty Barrett. I think we're going to go in order of the presentations. So a few questions on CRE specifically. The first question we got is bleach recommended for environmental cleaning for CRE cases in hospitals? And the general answer is no. Products that are effective against susceptible Enterobacter CA should also be effective against carbapenem-resistant Enterobacter CA. But we do want to make sure that facilities are adhering to the appropriate contact time for whatever the organism is that they're trying to remove from the environment. And keep in mind, if patients also have co-infections with other organisms, that the product should also be applicable for those. So say if somebody has a C. diff infection, they should make sure the product is also appropriate for C. diff as well. The second question we got is, for series in New Jersey, are most travel related? And in New Jersey, we have seen some travel-associated cases, particularly for some of the more novel resistance mechanisms in the United States, including NDM and OXA48. But we have and are seeing more cases of CRE and CPCRE where the patients only have domestic healthcare exposures as well. So we are still wanting to focus on preventing transmission locally and not just identifying those travel-associated cases. And the third question is, will New Jersey Department of Health be sending information regarding CRE testing and precaution to healthcare providers? We are working at the state level to develop some guidance materials, not only for local and providers, but also for laboratories who are participating in these projects. But I do want to highlight that CDC already has some resources available for not only investigation, but also containment of CRE, including a CRE toolkit. And the New York State Department of Health is the one developing a lot of the guidance for screening protocols as well.
And Patty, is CRS going to be reported in CDRSS?
All right, so pass it on to Kathleen.
Hi. So I believe the question that was just asked was if CRS is going to be reported in CDRSS. At the moment, it is not. Patty, I don't believe there are any future plans moving forward.
So for right now, Candida auris, while it is a big priority in New Jersey, it is not a reportable organism in New Jersey. And so we are hesitant to bring it onto CDRSS until we have a firm case definition set forth for Candida auris. So we're doing most of the reporting and response activities through other mechanisms outside of CDRSS at this time. The same also goes for CRE and CPCRE cases. While CRE is nationally notifiable, it is not reportable in New Jersey, so we have not onboarded any of these onto CDRSS specifically.
All right, some of the other questions we got for C. auris. The first is, are healthcare facilities made aware that they should be reporting suspect or confirmed C. auris cases to the local or state health department? So I do want to acknowledge that extensive outreach and presentations have been given to professional organizations such as APIC and IDSA, that healthcare providers really should be reporting any suspect or confirmed cases. When that fails, we have done a lot of work with our friends out in the labs in New Jersey. So when they identify a suspect isolate, they're usually giving us a call to give us a heads up. The second question is, why is C. auris so prevalent in the New Jersey and New York area? Is it because there is a greater awareness? So initially, C. auris came into the New Jersey area. We believe it was imported from other countries from travel-associated cases. Also, New Jersey has a very unique setup where cases will be in a hospital and then they go down to like a step-down unit, such as like a nursing home or an LTAC, but they still have really high level of care there that can promote the spread compared to other states where patients are just staying within hospitals. And of course, we really are focusing a lot of our efforts on screening patients, which other states might not be doing that as actively as us in New Jersey and our friends in New York. The last question is that the national map for C. auris shows that a majority of states have no rates reported at all. Is this due to limitations such as lab methods or associated costs? So at this point, there truly are no identified confirmed cases in these states. I do want to reiterate that map was for clinical cases, not for colonization cases. And also, if any labs do ever suspect that they have a C. auris isolate, the CDC and the AR lab network will confirm any suspect isolates at no charge for those facilities. Thank you.
All right, so I'm back with my friendly flu questions. So influenza B lineage testing. So much like influenza A, influenza B does have different subtypes. One is called Victoria and the other is called Yamagata. So those of you who have received a quadrivalent vaccine in the last few years, those vaccines now contain 2 different strains. Previously, they actually selected either a Yamagata or a Victoria lineage that was involved in the trivalent vaccine. In the quadrivalent vaccine, they now have something from both B influenza lineages. And so that testing is quite important as it helps us determine, again, vaccine effectiveness and what type of influenza B we're actually seeing, and if the trivalent vaccine is actually protective against that particular type of B. So the second question is, do acute care facilities need to report ILI, for example, from ED chief complaint logs? The answer is no. This information is directly obtained from the epicenter data, which contains chief complaint logs. So our information comes directly from an electronic system, which is in about 98% of all emergency departments in the state. So there is no need for manual reporting from acute care facilities for ILI. So can you provide more info on how the surveillance system used the general submission of absenteeism in schools and staff, and when it's due to vacation, dentists, et cetera, and has nothing to do with ILI? Well, that's very true. But we have been tracking trends in absenteeism data over time. And so, again, we are simply looking for the total census of a school and the number of students absent. In the CDRSS system, there's also an ability to put a predominant symptom if you're seeing something, and also to provide comment so that you can say, you know, a very large portion of your student population called out because of a field trip or a holiday or something like that. And that information is taken into account. And so while we don't know that all of those absenteeisms are associated with ILI per se, as we mentioned, when we overlay that data with other types of information that we're collecting, we can look at some of that school data and see if there's something else going on. And again, our school absenteeism data isn't just used for influenza, it's also used for other things to really look at outbreaks and things like that to see if the school might need some public health control measures implemented. And it's a way for us to quickly and easily reach out to the local health department and subsequently the school. So the fourth question is, an outbreak defined by a particular percentage, and the answer to that is absolutely no. We have been struggling with this percentage issue for a long time, and we have been reiterating there is no percent value that determines when an outbreak is occurring in a school or a long-term care facility. You really need to understand what the baseline levels are for illness in your centers, whether it be a school or a long-term care facility. That's why we highly recommend long-term care facilities to conduct routine surveillance. Because, of course, during the season in schools and in long-term care facilities, you may have respiratory illnesses that are occurring. What you want to be able to detect is when there's something that goes above and beyond just a single case or a single runny nose in a daycare, and be able to determine when those issues are occurring. So again, we recommend not looking at percentages, but rather collecting baseline data that you can compare against. And we certainly have systems in place here that you can help work through and partner with. The fifth question is, how does surveillance impact HIPAA and FERPA confidentiality agreements, and would a parental permission be a consideration? All public health agencies in New Jersey are HIPAA exempt, and therefore anything related to a communicable disease investigation can and should be provided to the state health department and local health departments. Can you provide a resource for fever definition and what type of thermometer? So fever, again, for ILI, we assume that's what this question is related to. It wasn't specifically asked, was on the second slide of my particular presentation. And again, it's greater than or equal to 100 degrees Fahrenheit. And any thermometer that's FDA approved is appropriate for use. We don't recommend, there are some like phone finger scanner things on the iPhone stuff. They're not reliable for tracking temperatures. Finally, looking for partners for ILI. We are always looking for partners either in schools or long-term care facilities. If you're interested in partnering with us, on the last page of my slide was an email. If you email influenza advisory group at doh.nj.gov, you can reach out to our staff, and we're happy to work with you to enroll you. And again, that email address is on the last page of my slides. Thank you.
And Lisa, don't leave because I can't answer this question. Can the New Jersey Department of Health provide information on encrypting process versus faxing?
So that's a great question. We cannot provide that. That's something that you're going to have to work directly with your information technology staff and in your local jurisdiction or in your state agencies or in your local agencies. Again, encryption is extremely important when you're talking about personal identifying information and working with your state and local partners on communicable disease investigations. It's our understanding that that is a requirement of acute care facilities, and they should have the capability to send encrypted emails. They may not like to send them that way, but that is a particular requirement, and you will begin to see more and more encrypted emails coming from the state health department, as that is a requirement from our email system.
Thank you.
Where does the 100 degrees fever come from? Like CDC or?
That is a standard, the definition of, so the question is, where does the fever definition come from? That is a standard nationwide definition that is utilized across the board in every single state. That is a national standard for defining a fever.
Great. Thank you. And just a couple, I can't get to all of them. My goodness. It is always so interesting to see what people pick up on. I will respond to those who emailed questions that I'm not able to respond to. I like this one. Are we to use PWID, people who inject drugs, instead of IVDU? PWID is kind of the new term that we're using. It's kind of like people living with HIV. They're people first. So we're putting people first. So we're making it a little bit softer, the terminology, and that does not include people who snort. That is people who do injecting. That was another one of the questions. And then I'm just going to do one more. And you're not going to like the answer. Is there any grant money going to local health departments for increased investigations? I'm sorry, no. The money's, no, sorry. We can look into that if there's another grant that comes up, but there at this time is no money for the local health departments. I think what we tried to do with the priority populations was to try to help those health departments who were overburdened, particularly with the Hep C cases, to really try to limit what the investigations could be, because we know there are many jurisdictions with a large caseload. So to try to help the limited resources that currently exist, that was why we did that. And again, for those of you who have just a couple cases who don't fall into those priority populations, hey, investigate all of them if you are so inclined. If you are able to, please investigate them all. But again, our prioritization was really just to help those health departments with limited resources, because there is no additional funding for you. So Sharif, any closing words that you'd like to give our webinar participants who are still hanging on?
Thank you so much for your time and attendance today. I hope you enjoyed our presentations, and I hope you did mark your calendar for February 13, our next webinar. And I also hope that we have a nice, reasonable influenza season. So thank you, you guys. All of you I wish you a happy holiday, and we will be talking soon. Thank you.
Thanks, everyone. Have a good day. This concludes the webinar.